Good morning, good afternoon, good evening, everyone. It's a great pleasure for me to welcome you today for this Partnership for Maternal, Newborn, and Child Health policy dialogue focusing on accountability, or I should say, the state of accountability in context of women, children, and adolescent health. We have an esteemed panel of experts who are joining us today to share their reflections, ideas, and suggestions on how we can strengthen accountability for women, children, and adolescents' health. Colleagues, it would be an understatement if I started this conversation by saying that we are meeting in challenging times. These are rather unprecedented situations that we are confronted with. The shifts in global policy landscape, the cut of aid available for work on women and children's health, particularly on sexual and reproductive health and rights, is redefining the way we look at the issues related to programming, implementation, and accountability related to women, children, and adolescents' health. But also, these issues are not divorced from the larger patterns that are setting hold. There are policy regressions that are increasing rapidly. There is also a rapid disinvestment and invisibilization of this agenda and larger attacks on gender equality that are becoming ever so visible in global, regional, and national contexts. What we also are becoming very aware about is that the multilateral system, the vanguard of protection at the global level for accountability, is simply not able to deliver on the promise anymore. The kind of geopolitical shifts that are resulting in stalemates are becoming ever so evident in negotiations, whether they are in global policy forums, in Geneva, or in New York, and they are starting to have their repercussions at the regional and national levels as well. We also have different permutations that are starting to set in. For instance, the compacts that are starting to be developed between United States and a number of countries around the world under the America First Global Health Strategy, which will have a defining impact, not just in terms of the areas covered under the agreements, but also specifics around data, data sharing, access to information, and the compliance requirements. In the backdrop of all of that, what does accountability even mean? And accountability of whom to who? To answer this and many more questions over the next 90 minutes, I have the pleasure of inviting my first two speakers, which is Professor Paul Hunt, an emeritus professor from University of Essex School of Law, and my dear friend Kemi, who's the Chief Global Advocacy Officer with Force Feminista. A couple of housekeeping rules before I hand it over to Kemi for her keynote address, followed by Paul. The first is that we have three segments to this conversation. We will have Paul and Kemi share their reflections. We will have opportunity for you to share your ideas, questions, comments through the Q&A function. Please do keep them coming. And I will try and go back to the speakers on that. We will then follow it up with the first panel, which will have with us Professor Naomi Hossain from the School of Oriental and African Studies in London, Professor Elizabeth Mason at the London School of Hygiene and Tropical Medicine, and the former chair of International Independent Accountability Panel, and Dr. Landry from the Africa CDC. We will then also have a segment of a few questions and answers to take back to the panel, and then the final panel, which will include Professor Sophia Griskin from University of Southern California, Professor Asha George from University of Cape Town, and finally, we will also have the pleasure of hearing from Dr. Walter Flores from Guatemala. So with that, and without much further ado, handing it over to you, Kemi, for your keynote address. Thank you.
Hi, Rajat. Thank you. I was struggling to unmute myself and come off camera. I don't know if I am. Okay, so I will just go ahead. Good morning, good afternoon, and good evening, colleagues. It's an absolute pleasure to be joining you. As Rajat mentioned, my name is Farikemi Akinfederin, and I lead the global advocacy team at Force Feminista. I'm really excited to be sharing with you all some reflections this morning to kick us off. Just to kind of like lay the foundation, as many of you know, we're actually here today because accountability is fundamental to health and well-being, especially for women, children, and adolescents. Without it, commitments are not honored, rights are not realized, and preventative deaths continue across different regions and different countries. So for us, really thinking, I think it's important to recognize that accountability is what we use to transform political promises into improved social services, improved health outcomes. So we shouldn't necessarily see it as an add-on, but actually a true driver of progress. But as you know, accountability cannot be sustained without people power. And that's really going to be the crux of what I'm going to be talking about, looking at how we center people power, especially at the national level. It requires us to think through how we support individuals and communities to be able to better understand their rights, to recognize their role in governance, and for them to have the freedom and the power to demand better. That really is the crux of it. And um, people power is really important because it provides us with the opportunity to make the connections between democracy, to make the connections between elections and social service and those health outcomes, and making sure that they are visible and actionable. And this is how accountability can become a living practice and not just a technical checklist or a theoretical framework in terms of the work that we're doing. But even though we know this, we realize, and based on what even Raja had already shared earlier, that building people power is becoming a lot harder these days. It's becoming a really, really big challenge. We see across the world deep closing of civic space. We see community voices being silenced, criminalized, or treated as threats to the status quo. We see resourcing in some contexts being weaponized and used to control and weaken civil society. And even though we are hearing more and more governments talking about and expressing their support for accountability, many of these structural issues are not changing. These structural constraints are continued to serve as roadblocks, from everything from vague budgeting and limited access to budgets to limited participatory mechanisms and to restrictive laws and policies, including fiscal policies that prevent meaningful engagement. And, while we see at a global and a regional level that we don't have a shortage of commitments, even one of the commitments that we are going to be looking closer at today, which is the WHA Resolution 77, but even to things like the Abuja Declaration that allocates 15%, that member states committed to allocating 50% for health financing, to Maputo Protocol, for example. These are all things that already exist. However, the challenge is translating these commitments into meaningful change, making these frameworks work for people every day, especially at the national level. And we've seen that there has not been enough energy resourcing gone to building people power on the ground. And this is really important for us to frame because we are seeing that the anti-rights and the anti-gender movement are making those investments. They've spent years intentionally organizing at community levels, shaping narratives, and mobilizing their base. So we need to basically match that level of investment or even exceed it if we truly want to be able to make sure that the issues of adolescent women's rights, children's rights and health are actually advanced. But even within this scope of challenging context, I definitely feel that there are amazing examples that continue to inspire me, and I'm sure inspire many of you in terms of the work, from the amazing work that an organization in Nigeria is doing to center and help citizens recognize that their office, the office of the citizen, is the most powerful office in terms of democracy, and not just political titles, to the work that we're seeing, regional groups doing around the Montevideo Consensus and the creation of a platform called Mira Catamiro, which my organization is working and have led that process. To work even at community level to really bring the voices of those systematically excluded, from the amazing work of partners like the YP Foundation, who's doing, youth service audits to make sure that budget allocation is actually leading to service provisions, or amazing work of organizations like Education as a Vaccine in Nigeria, that is working to make sure that young people are represented as part of their community health committees, and making sure that adolescent health is prioritized there, to work of, wonderful activists in the Philippines, Kulukan Youth Leadership Initiative, that is working with their local governments to make sure that schools have adequate wash facilities and are using wash scorecards to make sure that schools are responsive to the menstrual health and dignity needs within their places, and making sure that the relevant infrastructure is available. I think these are great, great, great opportunities. But I think one particular strategy that we have not done enough to be able to really push for accountability is the use of legal and strategic litigation strategies. I think this is something that can really crystallize and move us. And I know there are many organizations that are using this approach, and we've seen it have actually impact in terms of the African continent, with the work that many have been doing around expanding access to reproductive rights, using the Maputo framework, for example, as that legal instrument for which they're holding governments for accountable to the obligations that they made there. But even with all these examples, it's really important for us to be able to take inspiration, but to move to collectively think together in terms of concrete, actionable items that we can use to secure accountability and continue to advance accountability. And I'm just going to list out 4 really quickly and hand over to my amazing colleague, Professor Paul Hunt. One is making sure that we're investing deeply and consistently in building that people power. We need to make sure that we're funding community organizing, civic education, social accountability tools, and movements, not just projects. We need to actually fund the work of movements, because that is the foundation for which we can work with. Second of all, we need to work across sectors and across movements, especially to protect and to expand civic space. We cannot take away the issue of accountability from health, from democracy, from good governance, from information integrity, digital rights, anti-corruption. They are all connected, and we need to work in connected ways. The third is we need to do more investing in national and subnational capacity to leverage and use global and regional commitments as advocacy tools on the ground, to be able to challenge the status quo and to be able to push for translating these commitments into local demands and policy change. And the last thing is, I think it's important for us to resource at all levels. So at the global, at the regional, but also we need to put a lot more emphasis at the national level, and we need to fund multiple strategies and multiple approaches, as I mentioned, from the community-led systems to strategic litigations to social audits, so that these different approaches can really get us closer to the goal of ensuring that we go from promises to action. So with that being said, I really look forward to our continued conversation, and really happy to pass on the mic to Paul Hunt to also give his own welcoming remarks. Thank you all.
Thank you. Thank you very much for that, Kenny, and for laying it out so clearly, the need for us to move from promises to action, and the 4 concrete areas that you identified for us to move forward. Paul, welcome, really. You have made enormous contribution to the thinking and writing on this issue within the scope of work on human rights, on right to health, over the past decades, and also both within your capacity as the first UN Special Rapporteur on right to health, and then in multiple capacities, and most recently as the Commissioner of Human Rights for New Zealand. Welcome, Paul. Look forward to your reflections, and over to you.
Thank you very much, Rajat. Thank you to you and your colleagues for inviting me to say a few words in these very challenging times. Among the panelists, there are numerous friends from our earlier lives, and it feels a bit like a college reunion, actually. But it's my pleasure to reconnect with you, and it's a pleasure to make new connections with you, Kemi, and thank you for your remarks, and making connections with other new colleagues. As Kemi and I have agreed, I'll focus my remarks on accountability at the global level. Of course, accountability at the subnational and national levels, they're really vital. And Kemi has made some remarks about accountability at those levels. My focus will be briefly on the global level. And I've got 5 brief sets of personal reflections. The first is this. I really appreciate that the Partnership for Maternal Newborn Child Health recognizes the importance of accountability at the global level. For example, some 10 years ago, the partnership was involved in the Independent Accountability Panel. More recently, the partnership has organized accountability breakfasts in New York City to elevate the importance of accountability at all levels. And the partnership has organized today's accountability event. These and other initiatives demonstrate the partnership grasps the importance of accountability and tries to enhance accountability in practice. My second brief personal reflections are these. I've come to the view that the partnership cannot hold states, corporations, and multi-stakeholder partnerships to account. The partnership, I respectfully suggest, is not sufficiently at arm's length from states, corporations, and multi-stakeholder partnerships to hold them accountable. The partnership has a vital contribution to make towards accountability, which I'll come to in a moment, but I don't think it can be close to the actual holding of accountability. Of course, I might be wrong and colleagues might disagree, and that's what we're here to discuss. My third set of remarks are these. I suggest that for robust, independent accountability in global health, we have to look to what I call the people-centered human rights sphere, not the state-centered sphere, not the UN mechanisms, although, of course, they have an important role to play. Effective, authentic accountability for global health will have to be located in the people-centered sphere, close to communities, peoples, and social movements. And I respectfully suggest that we should encourage a coalition of independent global health organizations, such as, for example, the People's Health Movement, Health Poverty Action, MedAct, suitable health journals, and others. We should encourage such a coalition to establish a permanent panel to hold accountable selected states, corporations, and multi-stakeholder partnerships, and the panel to look also at selected manageable issues. The coalition would work closely with communities, peoples, and social movements. The coalition would appoint an accountability panel. The coalition would forward serious issues to the coalition's accountability panel. The accountability panel would publicly decide if states, corporations, and partnerships were discharging their human rights obligations. Would the accountability panel's decisions be binding? Of course they would not, but neither are the decisions of existing UN mechanisms binding. Please don't underestimate how much most, not all, most states, corporations, and multi-stakeholder partnerships hate to be held publicly accountable for violations of human rights. My fourth and penultimate point is this. Yesterday, the Health and Human Rights Journal published a special section on accountability and health rights. If you have the time, please take a look at the articles and viewpoints in the Health and Human Rights Journal for December. Professor Anuj Kapilashwamy and I co-edited this special section on accountability. And if you have time, please look at our editorial, which outlines the proposal I've just signaled. That is a new accountability proposal at the global level. And my last point is this. The Partnership for Maternal Newborn Child Health has a really important role to play in relation to this coalition of global health organizations and its accountability panel. The partnership's role is not to get too close to the accountability panel, but to provide the accountability panel with reliable scientific data and evidence on the issues forwarded to the accountability panel. Colleagues, for more information on these issues, please look at yesterday's issue of the Health and Human Rights Journal. Please look at the collection of papers on accountability from below, and including, please, if you can, the editorial, which sets out a new accountability proposal at the global health level. The editorial explicitly invites your comments. Thank you very much indeed, Rajat.
Thank you for that, Paul, and really appreciate the emphasis that you have helped bring on issues around independence, issues around people-centeredness, as you emphasized, and importantly also public-facing accountability, and what will it take, and the role that different organizations, entities can play in that regard in terms of delivering that, and especially I think as we look at the present landscape, not just in terms of the geopolitical shifts that are happening, but also a significant fundamental reset that is starting to take place of global health, which is also redefining the architecture and how we use this space as an opportunity to deliver on that promise of accountability. I do see a couple of comments which I would love to come back to both you and Kemi before we segue into our first panel. There is one comment in terms of there is an upsurge in terms of use of digital tools and technology, often used in terms of using and collating data and different monitoring techniques. What role do you see in terms of the different ideas? Kemi, you spoke about strengthening people power and investing in communities. Do you see these technological tools working in that regards, helping in some way, or deepening the divide? Paul, I guess the same applies to you. Does it work in terms of going away towards, I know we are talking about tools, not necessarily the processes. And the other question is, and I think this is also in a way both of you touched upon, is the community-led accountability, which you spoke about. But we do know, and that comes with its own risks often, and risk of reprisal, particularly when you are trying to hold those in power to account, and the risks that advocates such as yourself, Kemi, I know several Force Feminista partners have had much difficulties in doing the work that they do. So what are some of the ideas there? And increasingly, the flip side of strategic litigation, that is SLACs, we are starting to see being used by governments, by corporations to silence the critiques that are there. So maybe I can come to you, Kemi, first for brief reflections, and to you, Paul, and then we move on to the panel. Kemi?
Sure. Thanks so much, Rajat, for that. I'll start with the pieces of tools. I think definitely technology is adding a lot of value, and I think is really creating opportunities for us to be able to kind of, if I can say, roll the data up, and to be able to help us put it in a way that it's easy for communities to be able to use it to make a case. We've seen different things from the folks at YP and the folks in Nigeria using tech tools as a way to get young people's opinion about the quality of service and rolling this up and using that for advocacy. I think that's an amazing example. Or, for example, as I mentioned, Mira Catemiro, which means our eyes are watching you, which is a specific accountability tool that we have worked with at Force Feminista to really trace and see how well governments are meeting their commitments to the Montevideo Consensus, which was a regional agreement for the Cairo agenda. So I think that it's important for us to continue to use this in a very responsible way, because it can also be used against us as well in that process. And I think as long as people are thinking about issues of privacy, issues of accountability, even within that, I think that is definitely a lot of role for that. But we should not think that the creation of the tool is what accountability is, right? Because that's what many people have emphasized. Create the tool, but then we see that people are not using it in a way to truly transform and to push the agenda forward. So tools cannot replace a full mechanism. And I think that would be my take-home message around that. In terms of the reprisal, I think this is a really critical issue. And I think it's one of the major roadblocks, especially as we're seeing governments putting in place legal frameworks that actually limit civil society and limit activists from actually speaking. And I think there's opportunity for us the importance of really coming together and working across movements to be able to push back against that. But also, as we are working with activists, as we're working with movements, civil society on the ground, the importance of safety, security, and well-being as part of this is an important element that we need to put into our accountability frameworks to ensure that those activists can, quote unquote, live to fight another day, and not necessarily deal with burnout and not necessarily have situations in which they're criminalized or arrested because they are pushing against the status quo. And we have more than enough examples for where this has happened. And I think it's important for us to be putting that as part of the package to be able to support accountability that is centered on people. So I'll stop there and pass over to Paul. Thank you.
Thank you, Kemi. Paul, over to you.
Thanks, Kemi. Thanks, Rajat. Let me just make a couple of remarks about the community-led accountability. Of course, I don't have all the answers to this. This is really important, cutting-edge stuff. But perhaps just three points to underscore. My argument is that we need to pivot from focusing on state machinery and focusing on UN machinery when it comes to accountability. And we have to pivot towards looking to communities, peoples, and social movements and health organizations that are aligned with them. So I'm signaling a paradigm shift of human rights from below, accountability from below, because human rights belong to communities, peoples, social movements, and human rights need to be located within that sphere. Are there problems associated with that? Then for sure there are. I mean, one that hasn't been mentioned, but I will just briefly mention it, is that professionalized NGOs will have a really important role supporting the communities, peoples, and social movements. But those professionalized NGOs mustn't take over from the social movements, mustn't take over from the communities and the peoples. So that's one challenge that hasn't been mentioned. Another is that, and I don't know if this is if I'm being too clumsy about this, but some social movements are reactionary. Some are racist and sexist and xenophobic. So ways will be needed to distinguish between the reactionary and the other social movements. And this isn't going to be easy. My last point, because I'm out of time, but my last point is really just to underscore solidarity within social movements, within coalitions, within communities, amongst peoples. There is solidarity, which isn't enough, but it's a major resource and strength. So solidarity, transnational solidarity, translocal solidarity. Thank you very much, Kemi, for sharing this with me. I really appreciate it. And thank you again, Rajat.
Well, thank you. Thank you, both of you. And a very, very helpful segue, actually, to our first panel. And really a pleasure to welcome you, Naomi, Liz, and Landry to the conversation. And the focus, as we know, for the first panel is accountability that delivers. And what a pleasure to welcome you all at the back of this conversation between Kemi and Paul. And each of you bring a very distinct and different perspective. And if I may request, Naomi, if we can start with you and all the work that you have done looking at issues around redress and redress mechanisms, but also studying what are some of the barriers and challenges that individuals, communities face in terms of accessing redress mechanisms at the local level. Very much looking forward to hearing from you, and welcome once again. Over to you.
Thank you so much, Rajat, and thank you so much to the PMNCH for inviting me. You can hear me okay? Can, great. Thank you so much, because I find these issues of redress mechanisms really, really important and increasingly so. And I'm really pleased to have the opportunity to speak to experts and activists like yourselves in the health space, which is not exactly my area. So I just want to share a few reflections on grievance redress mechanisms or complaints mechanisms, which increasingly appear to be carrying a lot of the weight of accountability in a lot of different sectors, including in particular, in fact, health. And I'm going to draw on a little bit of the work that I've been doing with colleagues at the Accountability Research Center, that's Suchi Pandey, Accountability Research Center at American University, where Walter Flores is also a scholar, and also with Anu Joshi. I'm sure many of you know Anu Joshi's work, and she's at IDS Sussex. And also we've done quite a lot of work on feedback mechanisms during COVID in Bangladesh, with the Brack Institute of Governance and Development and also Rajshahi University. So I want to draw a bit on the learning from that to talk to you a little bit about why I'm a little bit anxious, let's say, about the effectiveness of grievance redress mechanisms, formal grievance redress mechanisms in the health sector. And, what I have to say, I think also really what Kemi and Paul both had to say really resonated with my own understanding of these issues. Kemi's view about the need for social movements, really active social movements, to be pushing for accountability from below. And also, Paul, your comments on accountability panels, I think really a lot for me to think about. But essentially, I think it's interesting that grievance redress mechanisms or complaint systems, there are so many of them now. They've really flooded the sectors, all of the big health, but other sectors as well. There's so many of these. But actually, there's very little known about how effectively they work, what they deliver for people. And I think that's really disastrous, really, because they have this great potential to strengthen accountability to the most marginalized, the most vulnerable people. And when you think about it, under what conditions can, say, a woman from a low-income background, from a marginalized community, go and hold accountable the officials in a health a clinic or a doctor, people who are of much higher social and political and economic status than they are? A grievance redress mechanism, at least in theory, gives that woman the power to actually hold those people to account. But that's in theory. In practice, it's actually very, very hard for people to use grievance redress mechanisms. I'm talking, in general, how they are in general designed and implemented currently. And there are several reasons for that. And one is very important in the developing world in particular, is that a lot of these grievance redress mechanisms are not actually set up to serve marginalized citizens. Many of them are actually ornamental. I think that's a word that we use. And many of them are, in fact, required under the conditions of loan or project agreements. So, for instance, if you get a loan from the World Bank or a fund from the World Bank, you have to have a GRM. You have to have a grievance redress mechanism. There isn't that much, in terms of criteria for how that should work or who that should serve, but you have to have one. So a lot of projects, a lot of schemes, a lot of governments, a lot of sectors have a grievance redress mechanism. It's also the case that a lot of these grievance redress mechanisms, supposedly about accountability and redress, are actually more about surveillance. Authoritarian governments really are quite good at delivering complaints systems, and it's a way of, if you like, preempting popular discontent. And then there is, and here I slightly part company with Kemi on her optimism, relative optimism about tech. Many of these grievance redress mechanisms rely really heavily on technology, on the use of big data. There's a kind of a dashboard mentality around policy making, which actually really is very, very far from what people's lived realities are, particularly when it comes to trying to get healthcare of any kind. And I think that the AI is not coming, it's already here in the grievance redress space. Many companies are already making lots and lots of money rolling out AI agents that can manage your complaints. And I will say only one thing about AI in complaint system in relation to accountability, which is that if you cannot explain how you got to an outcome, and that's going to be the case using AI agents, if you cannot explain how you got to an outcome, you cannot have answerability, which is one of the two core components of accountability. So I'm very skeptical that AI is going to increase accountability. It might make it faster to process data, and that will be a very good thing if it does. And the fact is that governments increasingly rely on online platforms that most people cannot navigate. I mean, I have a PhD. I go on these online systems and I'm absolutely flummoxed. And once you're in it, you don't know if you've done it right. You don't know how to track it or get feedback. It's very, very hard. In our Bangladesh survey of people's experience of feedback mechanisms during COVID, we found that by far the overwhelming majority of people, when they want to make a complaint about health services, want to go and do it in person. They want to do it face to face. They don't necessarily understand the language that the system is using. They want to go and register their complaint with someone that seems friendly, even if it is about the organization that they work for. So face-to-face is very, very important for most people, particularly for marginalized people. And another important point, and this is, what Kemi had to say really, really resonated with me because of this. Our research shows that individuals from marginalized backgrounds really have very limited chance of individually successfully making a complaint that results in redress, or better still, in some kind of policy change. Very, very hard for individuals to do that. You must have organized support. You must have civil society or social movement support. So, for instance, in the UK, we have something called the Patient Advisory Liaison Service, which helps people go through the process when they're having to make a complaint. Lots of countries have these sorts of services that are absolutely essential to have that kind of social, organized civil society support. Of course, many people don't even know they can complain. And when they do complain, they often find out that their complaint is not eligible. They've made the wrong kind of complaint. We hear this a lot in the analysis of what goes wrong with complaint systems, is that sometimes you find you've just done it wrong. You haven't made the right complaint, or you should be going to a different agency. It's all very complicated for most people to navigate. I think it's something you said, Paul, about the citizen-centered approach to health. This is what we need with grievance redress mechanisms. Right now, they're designed by and for states, and often by the computer, the ICT section of the ministry. They're not designed by and for the people who are supposed to use them. So the two other final points about why they so often fail is that many health systems just don't have the resources or the authority to respond. So people are complaining, well, there was no doctor in the clinic. And so what can you do if the government hasn't recruited enough doctors, if the doctors are leaving the service because they're not being paid properly, if they don't have the drugs to deal with whatever your complaint is? So we hear this a lot as well, that the frontline doctors, nurses, health system officials, and others get very frustrated and very demoralized. This is a very important finding in the literature, very demoralized by complaint systems that they cannot, in the best of faith, deliver on. They can't address the complaints. And that is why, for many people, we end up, after some time, discovering that they find that there's no real point complaining. It takes too long. They're very unsure of the results they're going to get. And these actually very often end up failing as accountability mechanisms. Well, that's a really negative commentary, I realize. I think there are implicitly lots of ways in which these can be improved, but the really critical one is organized civil society support to activate these mechanisms, make them work for people, redesign them so they work for people, redesign them so that they can be used to hold policymakers to account. I'll stop there.
Thank you. Thank you for that, Naomi. A lot to unpack there. And I do have to say, one of my own initial research looking at accountability mechanisms in a country context, we found that there was no dearth of them. There were about 14 operating at the same time, duplicative, and some of them rather defunct, but there was a semblance of accountability and redress mechanisms, even if they did not ever deliver. The interesting part of that was how much of that was being done under donor pressure to give the semblance and the functionality of accountability rather than to actually redress the harm that is happening. Lots to come back to you on, but I do want to go quickly to Liz now. Liz, you were the co-chair of the Independent Accountability Panel, one of those key leaps of faith, I would say, the global health system made in terms of addressing and establishing independent accountability for women, children, and adolescent health. And I know you grappled with a lot of those things, including a question that I think Naomi was touching upon. So what does redress and remedy even mean in context of a woman dying in childbirth? And so when you look at accountability and components of accountability, not just to 2030, but beyond, what are some of those key issues that you think must be part of this conversation that we need to address in terms of ensuring not just sustainability, but actually accountability that does deliver for women, children, and adolescents? Liz, over to you, and thank you again for joining.
Great to be here with you all. And I think that already the speakers, Paul, Kemi, and Naomi, have said a lot about what I was thinking to say and what I wanted to speak about. I have a few slides, but they're really just as a sort of background. If you could go to the next one. Can you go to the slide? Can you put it on slideshow and run through it quite quickly? No.
No, it's happening, Liz. There is just a slight delay.
Yeah. Okay. Just to say that independent accountability, I mean, we found as the IAP that it's essential to sustain progress up to when it was disbanded in 2020, but now thinking about the next 5 years and the time beyond. And the past mechanisms that from the Commission on Information and Accountability, the Independent Expert Review Group, the IAP, I think we demonstrated that accountability at the global level there did drive political attention and financing and results from the Commission. There were many commitments, the commitments to women and children's health, and the accountability mechanism tracked those commitments. So, for example, Bangladesh said they were going to train 3,000 midwives. What we did, you can take the slides off if they're not going to work, if you just take the slides off. What we did was check how many midwives have been trained. And following that, in fact, they've actually trained and they're using many more midwives. However, we found that the mechanisms lacked permanent institutionalization and they lacked protective financing. Now, whether that mechanism is global or local, Paul is suggesting more local, what we feel is that it actually probably should be both. Looking at accountability beyond 2030, the accountability mechanism can prevent reversal of hard-won gains, hard-won health gains. They can protect women, children, and adolescents during crises. Looking at the next one, please. Looking at the crisis situation. Who is actually protecting the women and children in Gaza? Who is protecting them in Cox's Bazar? Who is protecting them in Sudan at the moment? And I think that we need to be talking about those women and children in those crises situations, and at the highest level as well as at the local level, because at the local level, they literally don't have any voice. So the accountability mechanism can drive equity and rights-based service delivery, looking at what are the, for example, I mean, there is a report out in Scotland at the moment on the maternity services in Scotland. That was commissioned by the NHS Scotland, but it talked to women, it talked to the receivers of the service, it talked to the providers, the midwives, it's talked to managers. And what they found, some things were very, very simple that they could remedy. Others, more complicated. Everybody complains about lack of staffing. Is it lack of staffing or lack of the right person in the right time and the right place? So it can drive rights-based service delivery, and it can strengthen public trust in the health system. If you know, and I think that Naomi, you were sort of saying, you know, does the redress help or hinder? But if you know that somebody is talking or thinking and listening to you, then it can actually empower through the health service and anchors political commitments to measurable results. How do the two match up? I think this is very important. Next one. What we found from the MDGs and the SDGs is that with the IERG following with the IAP, that there was focus, and that focus was brought to the highest attention at the UN General Assembly. And I know the UN has got many, many faults, but at least all the heads of states are there. They do see that this is a mechanism that, you know, could have bite. On the other hand, if it's time limited, once it's dissolved, then ad hoc mechanisms are fairly fragile, and they're fragile at country level as well as they're fragile at global level. Next one, please. I think that we found that I think these are the lessons learned from 5 years in the IAP, and the lessons that we found really are the same as what Paul is talking about, the same as what Kemi's talking about, the same as what Naomi's talking about. We have to use accountability mechanisms to continually gather, evaluate evidence, stress ideas, and have country-led, but overall global mechanisms. Next, please. There was a wake-up call during COVID. The COVID pandemic disrupted essential PMNCH services. Adolescents faced huge crises, and the deepest reversals in gains was found in conflict, fragile settings. However, the whole focus was on the pandemic, on containing, managing, and looking at the future for pandemics. The agenda for women, children, and adolescents fell through the floor, and the accountability systems there were weakened when they were most needed. So I think that looking now for the next 5 years and looking beyond, we have to have mechanisms that are strong and robust. We have, next slide, we have a huge current opportunity. We have the WHA resolution from May this year. We have the World Health Day from WHO focusing on healthy beginnings, hopeful futures. Again, another huge opportunity. We have the G20 leaders. The Cyril Ramaphosa, the president of South Africa, ensured that women, children, adolescent health as a foundation for prosperity was a key takeaway from the G20 global leader or G20 leaders statement. And he recognized the importance of the elders, the health elders, in moving forward, making forward this movement. They need to be held to account. That these G20 have said, yes, it's important. What happens when it goes to the United States next year with all of the issues that have already been mentioned? We have this momentum, and we need to use this momentum now for the next 5 years to transition into post SDG architecture. And finally, just to say that the mechanisms that we have are suggesting in establishing a, okay, next slide, please, a permanent accountability body. We need to protect multi-year financing for accountability, institutionalize country accountability hubs or whatever mechanism we feel is most important at country level. And I think Paul has suggested one type of country mechanism. This can be linked with the redress mechanisms at country level, with minimum data sets. How do you use the data at country level where it's most important? But importantly, we also need to guarantee the youth voice, the civil society voice, the community voice. And I think that if we can look and take forward these recommended actions, then we can use them now for the next 5 years and in the post-2030 agenda. Thank you.
Thank you. Thank you so much, Liz, and some very, very clear ideas and suggestions. And I really like the initial few slides where you were calling out the challenge of holding accountability in crisis settings, but also the point that you made about accountability systems being weakened when they are often needed the most. And thank you for those some concrete suggestions, which is also a very nice segue to you, Landry, and welcome. Really, such a pleasure to have you with us from Africa CDC. And pretty much all speakers have now spoken about locally led, people-centered models of accountability. And I know you and your work at Africa CDC and what you are trying to do in terms of fostering that accountability to deliver, not just in context of financing commitments, but also in terms of primary healthcare more broadly, and building self-reliance. So over to you for your reflections. And I do see already a question to come back to you all before we move to the next panel. Welcome, Landry, over to you.
Oh, thank you. It's a great honor to be part of this distinguished panel this afternoon. I also want to send warm greetings from Africa CDC, the Director General of Dr. Jean Kaseya. Rajat, you can't believe it, but as we speak, we are hosting close to 35 African Union member states here in Addis Ababa. And we are reviewing what is now called the Lusaka Agenda Monitoring and Accountability Framework for Africa. So as we speak, I left the room to come for this panel, and I wanted to share with you some reflections. Because for the Partnership for Maternal, Newborn, Child, and Adolescent Health, as we look toward 2030 and post-2030, we cannot ignore one hard reality. It's the reality of our continent of 1.4, 1.5 billion people, where we still face significant challenges around maternal health, access to sexual reproductive health services, newborn and child health, and adolescent health, and the chronic barriers or the structural challenges that our member states are facing cannot be addressed if we do not put, as mentioned by previous speakers, accountability at the center of the equation. Because, as you mentioned, most of our primary care programs where those services are delivered have been relied a lot on donor support. 60 to 70% is in most of our countries over the past years. And the Lusaka agenda came to put forward the need for accountability in the partnership between recipient countries and donors. I really want to stress on 3 points here. The first one is accountability is also about respecting national priorities. I think it starts there because if there's a misalignment in that investment that is coming from external support, at the end of the day, it will not translate into results for the mother, for the child, and or the adolescent. Accountability also comes from the recipient countries. I think there was a clear call from previous speakers about how do we hold ourselves accountable when it comes to good governance, and how do we protect the voice of those who are raising issues around corruption in our systems. So accountability also comes from the side of how do we make good use of public money. Before we look into how good we have performed into allocating resources towards our health sector in line with the Abuja Declaration, we need to ensure that we have strong accountability mechanism for good public finance management. And Africa CDC is reinvesting in that space, because before we allocate more resources into the health sector, we can efficiently use resources that is allocated by our national governments and have greater impact. Linked to this, I want to highlight, Rajat, that the leadership of Africa CDC, in line with the call from our member states to develop an accountability and monitoring framework for the Lusaka agenda, has established a division that will serve as the secretariat at continental level. Because, as mentioned also by a previous speaker, we need to institutionalize accountability. And this is a way to affirm a commitment for accountability in the implementation of the 5 shifts of the Lusaka agenda. And for maternal, newborn, and adolescent health, it will provide that important leverage that has been missing, I would say has been missing, because over the past years, Rajat, the focus has been on domestic financing towards health programs, or from the ALMA side heavily on malaria prevention and treatment. But if we really want to bring the whole spectrum of maternal, newborn, and adolescent health, we need to invest into primary health care. We need to foster integration. And that's what the Lusaka agenda is bringing to our 55 member states moving forward. Let me end with a third point, the data. I was so happy to hear about looking into data's the new frontier, because at Africa CDC, we believe that the measurement will inform the outcome of our programs. And the data transformation that the digital transformation can bring in the whole narrative or the whole discourse on accountability can be definitely transformed. At Africa CDC, we are investing in the data and digital transformation, and the leadership of Africa CDC is looking at the digital and data transformation as one of the pillars of the new agenda of Africa health, security, and health sovereignty. Let me stop here, Rajat.
Thank you. Thank you. Much grateful, Landry, for those reflections and for your very, very helpful ideas and ultimately to all that you are doing at Africa CDC. Really remarkable work. I do have a follow-up question from one of the panelists, which I'm going to embellish it a little and add my own to it. And if I could have Liz, Naomi, and Landry to just be with us for another minute before we segue to the next panel. And the question is, what a lot of what we are talking about requires an all of government approach. A lot of action that we are talking about actually is outside often the health sector. And the issues that we are talking about do not necessarily fall into the typical, violations approach that there is a defined duty bearer and there is a defined, person or a victim, as you would say in a human rights parlance. So how does one bring in the ideas, Naomi, that you were talking about, and Liz, about the kind of future-looking perspectives on redress, on accountability through this all-of-government approach? And Landry, you touched upon it, so maybe we can go in that order as we started. And Naomi, to you first, and then Liz, and we end with you, Landry. Naomi?
I mean, it's an excellent question, and you're absolutely right. A lot of the accountability mechanisms, the legal and the political frameworks within which accountability mechanisms are designed and implemented are not exclusive to a single sector. Here again, I think, and maybe this is a cop-out and an easy answer, but here again, I think that what really matters is citizen pressure, is organized. Citizen pressure from below is a space for civil society to be able to be heard, to take a place, to take a seat at the table where the policies are being made, and then to sustain that pressure, over time, through close engagement with ministries, with people on the ground, but also in those flashpoints, in those moments when scandals occur, when crises occur, to be able to really, speak to the broader citizenry about what's going on, and call out, failures. It's very hard I think all governments really now want to have these kind of more accountable faces. They want to have effective grievance redress mechanisms. It's just like, well, almost any accountability reform does require an all of government response. But there are a lot of, we act like governments are uniform, homogenous entities, and they're just so not. There's a 1,000 different interests and stakes in either enabling or preventing accountability to come forward. So I think you need to be very politically, economically savvy when you're trying to introduce these reforms. And I think that's something that's sometimes missing.
You're muted, Rajat.
Sorry. Thanks, Naomi. Liz, over to you.
Yeah, I agree in that respect, and I think that we saw very well from the COVID response in different countries how overall it was seen as a health issue, but actually responses were financial, they were educational, they were, agricultural, nutritional, everything, because of the way that the shutdowns in most countries, affected people's everyday lives. And I think that in that respect, what we can see is if we really are caring about women, children, young people, then we have to work together with the different sectors that affect their lives. So the education, critically important, the social welfare, the agricultural sector in terms of food production and which are the sort of the right foods, the financial sector, and so on and so forth. And I think that in looking at an accountability mechanism, we need to be much broader in our conceptual thinking than we tend to be in the health sector. We tend to sort of look at things fairly narrowly, but we have to look and see how to broaden those out, which is why it's so exciting to see from the G20 health leaders, G20 leaders, not only the health leaders, them coming out with that statement. And so I think that, it is possible to be more broad and look multi-sectorally, even if you look at just the few most important sectors that are involved in the overall sort of right to health.
Thanks, Liz. Much appreciated. Landry, for the last word.
I think I can't agree more with the statement from Liz. There's a need for multi-sectorality. If you look at the way we are approaching primary healthcare transformation today, we are aiming to have a primary healthcare that is epidemic and outbreak ready, that is also pandemic ready and resilient. And that can't happen without multi-sectoral approach towards a primary healthcare system. I want to take, for example, the issue of maternal health. Today, there's a huge need to strengthen the data agenda for maternal mortality reduction. But that data agenda cannot be taught without access to electricity. And there's no need to have a 5G connection in a maternal ward where there's no water. And water, in most cases, is not under the responsibility.
You went on mute, Landry. Just last 30 seconds, yes.
Okay. So there's a need as we think about accountability in the space of the Partnership for Maternal, Newborn, and Adolescent Health to really encourage that whole of government approach. There's no way we will solve accountability for the outcomes with only the health sector around the table. Let me touch on the last point, the civil society. And the Lusaka agenda, as I mentioned to you, we are meeting here at Addis Ababa. We have civil society in the room. And the civil society has taught us a lot from the HIV and AIDS response. Their voices, when leveraged and the space when given to them, they can make miracle. And at this particular time when I think health financing is somehow the new crisis, as the DG of Africa CDC used to say. If we are making the analogy with an epidemic or a major multi-country outbreak, I think the health financing, the financing the health sector today, what our countries are facing, is similar to a multi-country outbreak. So it requires mechanisms that are similar to what we do when we are dealing with an outbreak. It requires multi-sectoral approach. And the civil society, in the case of the Lusaka agenda, are going to play a key role in the monitoring. They are going to play a key role in the social level data collection. They're going to play a key role in the voice of those who are the voiceless. And really want to encourage that multi-sectorality, not to forget about the civil society. Because the whole of government seem to look only as the government, as organized structure. But civil society should be considered as part of the whole of society approach.
Indeed. Thank you for that, Landry. And that's actually a very good segue into our last segment and the second panel, which we would like to focus on how do we then build stronger accountability mechanism. And a great pleasure for me to welcome Professor Asha George. And Asha, sorry for introducing you wrongly. Asha is at the University of Western Cape, not Cape Town. She lives in Cape Town. Asha, you have looked at, thought about, written on the complexity of some of these narratives, of the power relations, and much of what we have talked about in the last hour and a bit. And really looking forward to hearing from you, how does one navigate these complexities and power dynamics to make accountability deliver for women, children, and adolescents? And thanks again for joining us. Over to you, Asha.
Thank you. Thank you so much. Can you hear me all right? Perfect. Great. So I'm Asha George. I'm at the School of Public Health at UWC. I'm really delighted to be here to talk about accountability, which has been really at the heart of, is how I met Naomi a long time ago, because it was at the heart of a preoccupation I had when I worked on maternal health at the district level. And it's been a thread that And it's so amazing to see so many more people in the health sector talk about accountability than 25 years ago. It's really, I think it's phenomenal how different people have engaged, their communities of practice, many more NGOs and the health sector. Our frameworks have evolved, and that's very exciting. So accountability, in terms of an academic definition, is about transparency and answerability, which Naomi mentioned, which are the processes of review and redress. And they're absolutely key to make health systems more just. Health systems where power relations undermine the voices of those from marginalized backgrounds every day. These power relations need to be kept in check to ensure fairness, voice, and better health outcomes. And that's what accountability at its heart is about. It's about power. And I'm going to say something a little bit different. For me, the biggest power relation that underpins all health inequalities is that of ideology. And that's very much, I know at the global level, there's a huge contest of ideologies, but ideology permeates at all levels of the health sector. And it makes us rationalize that certain lives matter less, that certain people deserve less access to key resources, including life-saving, good quality healthcare. And it's important to recognize that. There are some ideologies that are framing how aid packages are developed, how services are delivered, the conditionalities, and ideologies that shape who has the right to be at the table. This ideology is part of the normalization of inequality and how it eats away at the moral fabric of our societies. It allows us to think, to sort of allow that health needs of women and children are seen as something related to charity rather than key investment for future economic growth and peace. It makes us, and I think it's important to recognize that the first thing that accountability can be helpful for is changing the frame. I'm going to now go from that broad point to how one area that I'm working with currently of how this affects the health sector and our responses to make health services more responsive. One part of this normalization of inequality is a link to the missing evidence base and the absolute policy silence linked to violence against health workers, particularly at the PHC level, which is key in addressing most of the health concerns of women and children. It's absolutely true that health workers must be held accountable. That was the driving interest for me when I worked in maternal health and documenting how women died in childbirth, that we need more accountable health services and more accountable health workers. But for them to respond to the needs of women and children, particularly those from marginalized groups, including LGBTQI users, migrants, whether they're legal or not, drug users, adolescents, whether they're married or not. That intersectional approach also needs to unpack the power relations that shape who are the health workers that work at the frontline service levels of our health systems. The majority of them at the bottom of our health systems are women, and they're actually vulnerable women whose rights are regularly trampled on. It's striking to me, and I'm really delighted WHO is updating the systematic reviews, but across multiple studies, 62% of health workers report being victims of violence. If you think about that statistic, that means 2/3 of our health workforce is traumatized and victimized. And they're traumatized during their duty to serve and care for other people. So I think that really changes the perspective on how we work with health workers to support accountability. The WHO ILO guidance is more than 20 years old, and I hope it's finally being updated despite the dismantling of our multilateral system. But it's striking that in some of the analysis we're doing in a consortium I'm leading called Imarisha, which is about strengthening PHC, is that our initial analysis of human resources for health policies is it's absolutely silent on workplace violence in the health sector. It's largely not mentioned at all. And let alone gendered workplace violence. So we have a lot to do in breaking the silence around this. We're completing a scoping review in South Africa. The other key thing about this was really striking. In the last 10 years, there's about 70 articles describing this problem, but it's mostly at a very descriptive level, measuring the extent of violence. There has been no intervention studies in South Africa, no implementation research, no co-designing of health system changes to address this problem. So we need to really go beyond, we need to name the issue, but we really need to forge the partnerships to look at how can we address this issue. And it's absolutely key, I'm just wrapping up now, that we really change the silence around gendered workplace violence faced by female health workers, particularly if we want to be taken seriously by health workers about being more responsive, about going the extra mile, about working tirelessly in terrible under-resourced systems. We need to really take their safety and their everyday lived experiences to heart. There are key allies, and they can be key agents of change. So I'm going to talk about three areas of change. One is to go beyond the numbers. The descriptive studies are important, but we need to put a human face to these experiences, to humanize health workers. They're not just inputs that we push around and put more and more tasks onto these community health workers. We need to elevate their voices and empower them to inform what works, what are the changes that need to happen in their context, and break the silence that undermines them. We need to also work with communities. I think a lot of the human resource response really looks at what can be done to make facilities more secure. But really, a lot of our primary healthcare is working with communities. And they know they can mobilize, particularly their key allies in addressing this. And I think particularly they could be a key ally for one thing that hasn't been mentioned in this area and is a weak spot for accountability, and that's the private sector. And at community level, private providers are deeply embedded in communities. So if we don't think strategically about how we work with communities on this agenda, they could be a key way also to address the private sector. And the last thing is to work from the bottom, but to manage up the health system. And Naomi already mentioned this, probably Walter will already. In the health sector, there are layers and layers of power inequalities. But a lot of the decision-making around financing, about recruitment, all these policies are at a higher level. So it's about creating coalitions for change. So really supporting voice, allyship, and political engagement is key in working with health workers to make a difference. Thank you.
No, thank you. Thank you, Asha. Much appreciate the remarks and the centrality that you brought in terms of where you started from about accountability is about power and voice and how do we navigate these complexity. Colleagues, I'm doing very poorly as a moderator, and that just to give a flag to you, we are likely to run over by about 10 minutes. And this is the consequence of a conversation that is so rich in content and detail. And we have two remarkable speakers next. And And Asha, you know already built it up for Walter in terms of working with the community and community level approaches. Welcome, Walter, and really handing it over to you for your reflections on what does really work when we talk about communities and navigating the complexities, the layers that previous speakers have also spoken about. I know you have slides. My colleague will
No,
upload them.
I'm not gonna use my slides anymore.
Oh,
It's
lovely.
fine.
So over to you, Walter, and then next is Professor Sophia Graskin as
Great.
well. Thank you.
Great. Thank you, everybody. So first, let me just explain what is community-led accountability. We have mentioned it a lot. So just to make it clear, is the monitoring and oversight to hold public officials to account for the provision of public goods and make them responsive to community needs. There are different approaches. There are village health committees, there are community scorecards, community defenders of health rights. But what is important to understand is that the community-led accountability is complementary to other types of accountability, such as the one done by Congress, Parliament, Ombudsman, even Supreme Audit. They have to work in tandem to make it effective. The second point that I want to make is, why do we need community-led accountability? I'm convinced that everybody, all countries need community-led accountability. And the reason is because progressive laws and commitments are no use if they are not implemented. We spend a lot of time in passing this progressive commitment, but then we do very little in terms of enforcement implementation. Also, we rely a lot on political will of decision makers, which is insufficient. We shouldn't rely that much only on political will. And the third reason why we need community-led accountability is that communities have a unique legitimacy to demand enforcement of rights and improve quality of healthcare services. It's a legitimacy that academics, researchers, and NGOs do not have. And that is the legitimacy that I'm demanding this improvement because I'm using those services. My only commitment and my only intention is to improve why the services that my family, my neighbors, and my community use. And I have seen it many times in many different countries. That has an effect and an impact on policymakers, on decision makers, that they cannot really push aside very easily as they do with NGOs or with academics, whatever evidence they bring. But the only reason is that I'm using those services, and I want to improve those services. And also, we have to be aware that women and children that are not rich isn't because of an accident, isn't because of totally absent resources. It is the effect of historical and structural exclusion. So that means that we need to understand community-led accountability within the broader frame of engaging with sociopolitical causes of health inequalities. For instance, in Guatemala, that we work with indigenous communities, the whole purpose of community-led accountability is one of different strategies to try to redress that historical and structural imbalance. And also, the purpose of community-led accountability is enabling communities to become agents of this process of redressing deficiencies, but also influencing what they do, the decisions for the health system. Okay, so what are the key strategies and action that work for community-led accountability? The first one is, do not think of starting with a tool of a method. That doesn't really work. It works and started by organizing, continue by organizing, and more organizing. What do I mean by that? I mean that community organized together with community activists. In the case of Guatemala, we organize as a network of community defenders of health rights. They have to identify what are the things that we need to become stronger in terms of a network, stronger of our influence. And one of the key components is rights literacy for their own communities. Mass campaigns of rights literacy through community radios, through days on the open market. That's very important to broaden the constituency or the base of the communities. The second one is doing the eliciting evidence of problems in the healthcare by doing the monitoring of healthcare services, looking at availability of medicines, equipment, infrastructure, emergency transport, and essential supplies. As you can imagine, this monitoring will bring issues, will elicit problems, will elicit complaints. So a central component of a community-led accountability that works is not to stay or leave the complaints on its own. Those complaints need to be resolved. So community-led accountability has to have mechanisms for redressal at the local level or whatever the level that denials of services occurring or that the bribery or asking for money is occurring. So one of the key work of these community health defenders is to do mediation and conflict resolution when there are complaints of denial of services and bribery, etc. So redressal immediately at the local level is very important part of community-led accountability. Not only collecting data on the monitoring, is redressal those complaints. The next one is a strategic advocacy at all levels, at local, provincial, and national, connecting those different levels. And the last one is this idea of training community defenders, expanding the network all the time, thinking how to expand the network, how to become stronger. Just let me mention some of the achievements that we have seen in Guatemala through this community-led accountability. We have seen improved responsiveness by authorities to complaints of ethnic discrimination and poor quality of care. We have seen increased allocation of public resources for medicine and other essential supplies. We have seen increased trust through this mediation and resolution of complaints, and also the expansion of the network. We started 10 years ago with 5 community defenders in 5 municipalities. Now we have 150 defenders in 35 municipalities. All of them, they are volunteers. This network is volunteer-led, it's community-led. It doesn't depend on external funding to do this work, just for the technical assistance and some minor equipment. And also because of the power that they have grown and the influence, now they are working in municipalities to do co-creation of public policy at municipal level. Also, they have been scaling up the work of community-led accountability to other sectors that are essential for community, such as education, school feeding programs, but also emergency response to extreme weather events caused by climate change. Communities themselves have expanded into those sectors with the work on community-led accountability. Okay, so as a final key lesson that I want to leave here as well is that we have to see that this is a long-term strategy and engagement. This is not something that we have quick results. We have been working for about 10 years in this process. So it's a long-term engagement. It's not a single project. You have to think in the longer term. Also, it's really important the municipal and local government level. All of us want to work with the national level, want to influence the national level. Yes, that's good, but once you influence a specific policy, that has to be implemented. And this is implemented by local services, by municipal government. If they do not have either the capacity, the skills, or the interest implemented that, all the effort that we did at the national level is not going to work. So it's extremely important to work with the national level, the municipal level, especially that in many countries, the municipal government have autonomy in decision making. So you can do a lot with municipal policies. Also, forging this collaboration with authorities, key health actors, but at the same time, community-led accountability, communities maintaining independence. That means community not depending from NGOs, from funders, from political parties, for none of those, only for the communities themselves. So all of us has to be committed that if we are supporting community-led accountability, it's not because it's going to be our project, it's going to be our communities. We are only contributing, we are only third parties, we are only intermediaries, but they are with their independence. And the final comment that I want to give is that we should understand community-led accountability as one of the different strategies in countervailing power to promote democratic governance of health system. Not as an administrative tool, not as just one technical action, but countervailing power. I'll stop here. Thank you.
Excellent remarks, Walter. Thank you so much. And a lot to unpack there. time is unfortunately not on our side, but at the same time, I do want to not lose the thread about some of the critical elements you talked through the remarks in terms of long-term nature of reflection that we need to build, investments that are required to understand and an unpack redressal, something which Nomi was talking about too, and the elements of trust and what we can achieve and not achieve through these processes, which is a brilliant way to come to our last presenter, last but certainly not the least, Professor Sofia Graskin from University of Southern California. Sofia, you've been working on health and human rights for decades now, and you have looked at frameworks, what works, what delivers in terms of legal accountability, the complexity, the challenges, and all 9 yards, as one would say. From where you look at it today, do you really think it works? And what would, in your view, can legal accountability do in the present context? Welcome, Sophia. Over to you.
Thanks, Rajat. It's really been incredible to hear these conversations. I'm incredibly grateful to be here. I have to say a lot of this resonates with my own thinking, which is great, but I now have more questions and thoughts about accountability than when we began. So I guess I'm grateful for that. But you'd asked me to speak about aligning public health and legal approaches, and I'm going to do that. But if you will allow me, I want to try, as others have done, I need to situate my remarks in the political moment that we're living in. You know, the concept note emphasizes that we're meeting in a time of fiscal tightening, political instability, shrinking civic space, deepening inequities. But for accountability, these aren't abstractions. They are manifesting alongside widening divides in economics and health and political views and social values. You know, we've always had to ensure accountability for who gets sick and why, who gets left behind and why. That is language we all know well. But the core values that underlie our ability to do this work, including the values that I think we would call human rights, are, as I think we all know, under open assault, right? We are seeing escalating and highly organized attacks against gender equality, against sexuality, against reproductive freedom, against bodily autonomy. And we add to that what others have talked about around climate and other emergencies and conflict. The pressures around accountability for SRHR multiply. And I just have to say one more time, this is all unfolding alongside rising nationalism, populism, disinformation. I live in the US, so I see it here. But sadly, as I think we all know, this is not only a problem in my country or for those who have to deal with my country. All of this is in the moment, what a reality we're dealing with. So I wanted to give one concrete example where these dynamics converge that I think are relevant to our conversation about accountability. And that is the growth in abusive and harmful laws across the world that are being used to target and harass people seeking to access certain health services, and in particular, gender-affirming care or abortion services. So in thinking about accountability, these raise urgent questions. Who is responsible for the harms that these laws cause? Lawmakers, the civil society actors who champion them, the systems that are implementing them, the providers who are turning people away or worse, reporting them. But I want to get into what about those who feel compelled to comply to keep their jobs? Is it fair to hold frontline workers accountable for behaviors where they are simply following the law? These aren't theoretical questions. They take us back in history, and they really have to go to the heart of how we think about accountability going forward. More broadly, this pushback against SRHR is deeply tied to the broader pushback happening against democracy and civic space that Kemi and others have spoken about. States often begin broader clampdowns on human rights by restricting rights tied to identity and bodily autonomy, all of which are ultimately about controlling how people live their lives. You know, so many colleagues have said if we're going to talk about accountability, we can't ignore how these political dynamics are shaping what is or what's going to be possible. And especially when our basic governance systems, and let's be honest, they were never adequate to begin with, are now really shaken to their very foundations, including, even as has been said, the legitimacy of multilaterals and of democracy and democratic structures. I strongly believe in civil society's ability to demand accountability, but we have to address how difficult this role becomes for civil society when rights, excuse me, and the civic space they count on in order to demand that accountability are eroding at this crazy pace, which of course leads to, well, what is even possible now? How can we design accountability mechanisms for a moment when the systems that we rely on, legal, political, institutional, are, let me try to be polite here, fraying? And how do we avoid, even if we're well-intentioned, making things worse? For example, reinforcing inequities or unintentionally shifting blame downward, especially onto frontline workers and marginalized communities. There have been a lot of excellent suggestions made by my colleagues, so I don't just talk about accountability simply in the abstract. I want to be clear, we have to be explicit in every instance what we are seeking from accountability. There's so many different definitions out there still. PMNCH defines accountability as being answerable for actions and results, which I really appreciate because it's not just punitive, and it would also include ostensibly celebrating progress. But clarity is needed every time. Who is answerable? To whom? For what? In what for? To what end? And that these answers are going to vary across maternal health, newborn health, child health, and adolescent health. The broader context, sure, those overlap, but the actors, the funders, the legal networks, the programmatic responsibilities, those differ. And these differences have to be named and addressed each time rather than just assumed. So I want to suggest 5 questions to guide determination of which accountability mechanisms might be most relevant. And the first is how broadly or narrowly you define the issue. The scope is key. A harmful law demands a different mechanism than a facility level quality of care concern, even if the reality is that it's the law that shaped the harmful way the care was delivered. And second, like, who are we holding accountable? The government, donors, facilities, health workers, private actors. And remember that harms often result from actions across multiple levels. So identifying the right duty bearer may take time and might not be as obvious as one thinks, even if it's essential. And then when we talk about accountability, but for what precisely? The law, its implementation, the standards of care within a service, a specific harm to an individual, health outcomes at a population level. I mean, I say that because given that structural determinants drive 70 to 90% of inequities, is it sufficient to focus only on the harms caused by one very narrow law? And finally, what outcomes are we seeking? Is it remedy? Is it redress? Is it a report for decision making? Is it public awareness? Is it structural reform? Which mechanisms is going to be most appropriate is going to be determined by all of these questions. And we need to think about a whole lot of different kinds of mechanisms that have been talked about today. So the question has to be, and they all serve different purposes. So the question has to be, where are we going to get the most clear result for the issue we are concerned with each time? And how are we going to use information to drive that decision? So without clarity in my mind on these points, whatever we do about accountability risks becoming an empty word, or worse, shifting blame downward onto those with the least power without actual accountability for what's happened at the top. So let me just to close what I'm finally supposed to do and just say something about public health approaches. They're indispensable. Public health gives us systematic monitoring, disaggregated data, and some degree of identification of disparities. But there are limits. Public health often privileges averages over outliers, leaving out the very populations that experience the deepest inequities. Public health describes inequities more easily than it produces remedies, and it can underplay the political forces that shape health outcomes. And legal approaches can address some of those gaps by articulating duties and obligations, not just aspirations or optional commitments. So when a system is functioning, it can offer pathways for redress, for policy reforms, and at times structural change. It can bring consequences into the accountability conversation. But legal pathways also have constraints. They're slow, expensive, inaccessible often to those who most need them, and oriented more towards individual violations rather than systemic transformation. And they can, it must be said, they're not just weak, but often they're corrupt. So with public health, Legal strategies can't be expected to truly solve problems rooted in political will and power dynamics. So legal accountability, not a replacement for public health accountability or vice versa. Together, they can expand what's possible. Combined, if systems are functioning, they can ensure data are not just collected, but acted upon with mechanisms for corrective action and ideally monitoring over time. Where I hope we can align is that accountability efforts should produce remedies, not just reports. And we've all been there. Reports that describe inequities without change is not accountability. And to move forward, as all in this webinar have said, I think we have to name the realities of the current moment. And doing so requires courage. Courage to confront the politics of inequality, to call out systems that are failing, and from my perspective, honestly, to reassert the values of all that human rights can offer. And I think we all see this, but we have to address this not just as a technocratic moment, but as a deeply political one, a moment in which, if accountability is to be real, we have to collectively confront questions of power, of visibility, and the conditions that communities need to actually be able to make those claims. And I think all of that is key to ensuring that the health of women, children, and adolescents is centered. And I don't mean in rhetoric, but I mean in results. And I'll stop there. Thanks.
Thank you. Thank you for that, Sophia. Remarkable, really. We are grossly over time, and I don't want to keep people for longer, and neither will I attempt to summarize the conversation. I think for all that you guys have said over the last 90 plus minutes, actually, maybe we need a whole symposium to unpack some of those ideas that have come through. But importantly, there are a few things that came out very starkly in the conversation, the need for us to probably start rethinking the notions of accountability, but also what does redress even mean today? And how do we define what are we talking about? You set a set of 5 questions, Sophia, with which you ended, but I think there are many more. Walter, you brought in a element that we are seeing increasingly being brought to the partnership in its conversation, that is the idea of trust. And we conducted recently a survey across 20 countries and with the impact of aid cuts and what is the experience of frontline organizations working on the plethora of issues we are talking about. And one of the first casualties that they pointed out was the breakdown of trust in the system, in the healthcare facilities, in the donors that they are so dependent on right now. Where do we go from here? Because what is clear is that the systems and processes that we cherish so much are unlikely to deliver in the landscape that we are in right now. We need to rethink, recast, and probably redefine the ideas that came through in terms of community level systems, etc., are very powerful. But I do have to say, we did not talk about what's happening to the shrinking civic space. We did not talk about what is happening to the attacks on civil society organizations working at the grassroots, protecting about these issues. So how do we address these issues and the complexity of challenges that we need to work on? It is a real challenge, not just for the issues that we have talked about, but for entities like us as well, because we do need to redefine and redouble our efforts if we are going to be true as a partnership that works on women, children, and adolescents. Thank you so much. We will be sharing a recording through social media channels of this remarkable conversation. But in 2026, we will come back to some of those specific ideas that came through the variety of presenters today and built upon further conversations and dialogue, and hopefully, inshallah, for some concrete actions that can help deliver for women, children, and young people in these challenging times. Thank you, and hope you have a lovely rest of the day where you are.